Hello, dear colleagues. My name is Álvaro González Cantero. I'm a dermatologist in Madrid, Spain, and it's my great pleasure to present today our work on statins and psoriasis. So what I want to present here is this position statement we have done as with the task force, with the psoriasis task force of the European Society of Dermatology and Venereology, together with eminent colleagues, Professor Wenke, cardiologist, Professor De Sutter, Zamorano, and also Professor Lambert and Professor Dr. Puig. So I will drive you through our work, and this is the introduction. As an introduction, well, we all know that our patients with psoriasis have an increased risk of myocardial infarction, and especially if you look at the younger ages, the increased risk of myocardial infarction is when they are young patients. So we don't have much time to lose here. Also, when we talk about mortality, we know that our patients with psoriasis have 5 years of life lost, being cardiovascular mortality, the leading cause in our patient with psoriasis. And again, when you look at the age of 40, those lines are separated, and there is an age interaction here that we should be aware also. This has been validated in recent systematic review and meta-analysis about this increased risk of mortality from all causes in patients with psoriasis. And Professor Wenke, here in this paper on the unmet need in psoriasis, he suggested that we should manage the whole patient, and this is urgently needed, and we should look for new ways to assess this cumulative inflammatory burden of our patients, and we should determine mortality as a clinically most meaningful endpoint in our patients. So here comes statins, and this is an independent Cochrane review which they intend to review the role of statins for the primary prevention of cardiovascular disease, and they found that there was a reduction in not only cardiovascular mortality, but in all-cause mortality, including cancers and other diseases, with no excess of adverse events. And here is why they are so interested in our field of psoriasis and for our patients, because we have an increased risk of mortality. And here we have some cheap drugs with no excess of adverse events, showing reduction in all cause of mortality. So this is our objective, to provide the dermatologist with a tool for systematizing the treatment of dyslipidemia in psoriasis, which generally escapes the scope of a dermatology, but we need to facilitate the decision-making about the referral and treatment of these patients. So when we go to the cardiology guidelines, psoriasis is already included in both the European and the American guidelines of cardiologists. Both of them include now psoriasis in their risk factors. But we know that these cardiovascular risk factors are under-screened, and especially dyslipidemia, and also under-managed in our patients with psoriasis. We know when we talk about statins and psoriasis that there is even a meta-analysis of randomized controlled trials showing an improvement in psoriasis, particularly in patients with severe psoriasis. So we could also have more benefits here. But when we go to the cardiology guidelines, they are so complicated. They have a lot of pages. There are complicated graphs that we dermatologists find complicated. So what we want to do here in deep position statement is to facilitate, to make a nice, simple summary for dermatologists of these cardiology guidelines. And this is the results of what we wanted to bring you here, this position statement on statins and psoriasis. Here we have the methods. We have the steering committee. We do a bibliography search, and then we did a Delphi consensus for the statements. We did a 2-round Delphi consensus that I'm going to show you here some highlights of. So these are the first concepts and recommendations. I have already mentioned that the life expectancy in these patients with psoriasis is reduced by 4 to 5 years due to cardiovascular disease, and that we know that in psoriasis, this lipidemia is underdiagnosed and undertreated. So, on the benefits of statins, we know that they have some pleiotropic effects of statins, which includes anti-inflammatory and antioxidant effects. We also have mentioned that this meta-analysis showing some mild improvements in the skin of patients with psoriasis, but also this reducing all-cause mortality with no excess of adverse events. So what about cardiovascular risk screening in our patient with psoriasis? Well, we here suggest to do a proactive approach to screening for cardiovascular risk, which is critical. For many of our patients, we currently have the blood test of most of them who are on biologics or systemic, so it could be really simple if we know, for example, the LDL levels that we should look for. Also, we propose a baseline assessment of lipid levels in patients with psoriasis, and then do a more frequent assessment in patients with moderate to severe psoriasis. And also, we should evaluate in our patients the body mass index, blood pressure, cholesterol levels, and also hemoglobin A1C periodically in our patient together with the lipids. So for me, this is one of the most interesting slides I'm going to present here. And is that during the last years, the objective, the goal levels, the LDL levels has been changing dramatically. And now look at here in the green color that a low to moderate risk patient should have a level of 100 milligrams per deciliter. So this is important for us to know because we are going to see the blood test of our patients and we need to know which our goal should be in these patients. Also interesting to include that a patient with psoriasis or in the general population with diabetes should have a goal of 70 milligrams per deciliter. And if a patient have an LDL of over 190, that's an indication for statins. Also, we include there a link for the European Society of Cardiology calculator, the cardiovascular risk calculator, so you can see where your patient fits and which your goal currently is. So now we know the current goals. So what do we need to do with our patient? Okay, so maybe initiate the statin or to send to another specialist who is going to prescribe the statin. When you need a 50% reduction, when your aim is a 50% reduction based on the goal mentioned before, you should initiate a high-intensity treatment with a statin. You have there some examples, such as, for example, atorvastatin 40 milligrams daily. Then, when your objective is a goal is in between the 30 to 49% LDL reduction, you should start a moderate intensity treatment. And then, very important, when your patient, when you see in a blood test an LDL level over 190 milligrams per deciliter, that's an indication for high-intensity statin therapy. So if you see this in the blood test of your patient, you should or initiate the statin or to refer to a specialist who is going to begin this. Also, if your patient has diabetes, you should check that he has an statin. And again, if not, you can initiate or send to the endocrinologist who for sure is going to initiate the statin. And also if your patient has subclinical atherosclerosis. So what about the follow-up? Well, you need a blood test 4 to 12 weeks after the statin is initiated. And there you will see about your aim, the percentage of response after initiated, or whether you need to change the dose of the statin in your patient. Then about the follow-up is not so strict as you can see here. It can be every 3 months or every 12 months. And these adapt really, really well to what we do with our patients on biologics or on systemics. So again, this can be really easy to do in our daily basis, at least for our patients with moderate to severe psoriasis. There you can see what to do if some of the blood tests is abnormal on the ALTs or even in the C case. So when to refer to other specialists is quite easy for us to know. It depends on the role we want to have in these statins recommendations. But you know that if you have a patient with diabetes mellitus, chronic kidney disease, familial hypercholesterolemia, or others, but you should refer to other patient. And also on the third point, that the use of statins only on the basis of the presence of psoriasis is not recommended. We need to have a high LDL level, as we have mentioned before, or diabetes or other thing that we have mentioned before. So I hope you find this summary interesting and that this paper that we have shown you here is useful to you. Thank you very much to all the people for your attention.